Hello again, and welcome back to the Oncology Brothers podcast. Another exciting annual ASCO is in the books. I'm Rahul Gossain, and along with my brother and co-host, Rohit Gossain, we're bringing you highlights from this conference. There's so much to learn and apply, all from here in our day-to-day practice, to dissect some of the data that we just saw here at ASCO 2024, or as many were calling this as ASCO Lung. We're joined by none other than Dr. Joshua Sabari, a thoracic medical oncologist from NYU. In our talk today with Dr. Sabari, we hope to focus on two plenary discussions and then build up on the theme of precision medicine by touching on anti-EGFR therapy and ALK inhibitors. Josh, thank you so much for joining us.
Thank you, Rahul, for having me. Rohit, thank you. I'm a huge fan, so looking forward to the discussion.
Thanks so much, Josh. That's very kind of you. Let's get rolling. We have quite a bit to cover. Over the next few minutes, let's dive in with our first study, LAURA trial. Testing for NGS is extremely important every cancer. Another actionable mutation in lung cancer, ALK positive. Here we have alectinib, lorlatinib, and brigatinib available for metastatic non-small cell lung cancer. CROWN study is an update on lorlatinib, and PFS is commendable. However, this is coming at a cost of higher toxicities. Josh, your go-to ALK inhibitor, post-CROWN data, and thoughts on the study, please.
Yeah, I think this data was impressive, but I'm still an alectinib guy in the frontline setting, and I'll talk to you why. I think there are some patients where I will consider transitioning to lorlatinib. So this is an impressive study, right? 300 patients randomized 1-to-1 to lorlatinib versus crizotinib. And, if you do NGS in all your patients, which you should do, you're going to pick up 3 to 4% of these in your non-small cell lung cancer population. This is phenomenal data. You see response rates that are, 80% plus, and look at this progression-free survival here. I don't think I've ever seen a curve like this. I know I haven't been doing oncology for that long, but, you could drive 4 or 5 trucks through these curves. The median progression-free survival here for, lorlatinib not reached at 5 years. So 60% of patients are still progression-free versus when you look at crizotinib, and a lot of people argue, but, crizotinib is irrelevant in 2024, but that was a historical control here. It's 8% are progression-free at 5 years, excuse me. So, hazard ratios here are numbers that I've never seen in my clinical practice. And if you look at the intracranial progression-free survival, lorlatinib is really, really impressive. Hazard ratio of 0.08. I don't know, Rahul, have you ever seen a number like that in your practice?
Yeah, now this is amazing. Our patients are living longer, and this is a very good problem to have, saying which ALK inhibitor I'm going to pick. This is phenomenal.
Yeah, I think the one issue here is the toxicity, right? And, you have to have a frank conversation with your patients. Alectinib, very well tolerated, does have some constipation, and it can have some skin changes, some liver test abnormalities, especially elevations in bilirubin. But when you look at lorlatinib, the major toxicities are really the neurocognitive toxicities, the sort of ataxia, gait issues sometimes, and personality changes as well. And I think of a patient who's a young lawyer, 34 years old. I really want him to continue to function, to work, to be with his family. So you have to have these discussions with patients. Now, in a patient who has significant burden of brain metastases, or a patient with these tier 3 variants, these are these rare ALK fusion variants that we know patients don't benefit as well from alectinib and brigatinib. In that patient population, I may consider utilizing lorlatinib in the front line. I'm curious if you guys would use lorlatinib or alectinib in the front line setting if you saw a patient in clinic tomorrow.
Yeah, thanks for your thing.